Hello friends, today I am going to talk about transposition physiology in cyanotic heart diseases, and this is an important topic because students often find it very difficult to understand, but one of the most common cyanotic heart disease presenting in the neonatal period is transposition physiology. So let us begin. The problem with the transposition physiology is that in the embryonic development of the heart, the truncus arteriosus fails to spirally twist and resulting in abnormal connection of the major vessels to the heart chambers. So instead of connecting to the right ventricle, the pulmonary artery connects to the left ventricle and the aorta attaches itself to the right ventricle. So this results in impossible type of circulation, which is in two independent sets of circulation. So normally what happens is systemic blood flow enters the lungs, and through the enter lungs it goes to the left atrium and then goes to the other body parts. But here this connection is lost because the right ventricle again pumps the blood into the aorta, which the blood goes to the systemic circulation. So you can also imagine that survival is not possible in such a circumstance. So that is exactly the case. For some time, the life sustains because of patent ductus arteriosus, which connects the two circulations for some time, allows the mixing of the blood, and very severely the patient is hypoxemic. You will find that some of the patients are born with antenatal diagnosis of dTGA, and they are having severe hypoxemia at the birth, and they can have severe bradycardia arising because of myocardial ischemia, and there may be tachypnea. One important finding will be that lungs will be X-ray of the lungs will be very clear with no response to external oxygen support, because you know that here the problem is not with the lungs, it is with the circulation. So the mixing of the blood is required for the systemic blood to have some oxygen, and that is the basis of understanding how we treat this condition. On X-ray you will find the heart is egg-shaped with a narrow mediastinum. So this is classically described as egg-on-string appearance on X-ray. The lungs will be clear, and cyanosis will be soon starting of the birth, and on echo you will find a parallel vessel root sign. This is diagnostic of dTGA, and this is the possible survival of this condition is whenever there is a communication between the left side and the right side. So we can have patent ductus arteriosus patency for few days, which maintains the connection, and you can have a atrial septal defect, which can be natural, when it will be helping us to sustain the life. Otherwise we have to surgically create it, or a ventricular septal defect, which can allow the mixing of the blood. But commonly we find that pulmonary connection to the aorta is through the ductus arteriosus, and it is vital to maintain the patency of the ductus arteriosus for the first few days, and we achieve that by giving intravenous prostaglandin E1. So what this prostaglandin E1 will do, this will maintain the patency of the ductus arteriosus, and the pulmonary and the systemic circulation, they will be mixing at this level, and the life can be sustained for some time. Definitely the child needs a intervention beyond that, because we cannot maintain the patency of the ductus for long, and very soon we have to resort to a surgery known as atrial septostomy. We artificially create a hole in the atrial septum, and thereby creating the mixing of the blood at the atrial level. So this is a time buying procedure, and it is known as Raskin's procedure. Many MCQs are coming in NEET PG exams, and this is the name of the procedure, Raskin procedure, where atrial septostomy is created artificially. And then atrial switch operation or the arterial switch operation is done, which are the major procedures. The atrial switch is obtained by mustard or sanding procedure. The arterial switch, that is the reconnection of the arteries to the ventricles, is known as Jatine's procedure. So these are the major procedures which are carried out when the child is 3 to 4 weeks old, and this ensures the long-term hemodynamic stability by coming to the natural anatomy of the heart as far as possible. We should remember that these are very technically demanding procedures, and they are carried by very experienced cardiothoracic surgeons, and the expertise level required is very, very high. Sometimes arterial switch is also not sufficient, so another procedure known as Rastelli's procedure is carried out. The details of these procedures is beyond the scope of our today's talk, and in general not much questions are asked about exact surgical mechanisms. So in summary, we have a patient of dTGA presenting with severe cyanosis because of parallel circuits, and within hours we have to start the prostaglandin E1 so that the ductus does not close and the two circulations communicate. Some more mixing is achieved by balloon septostomy procedure, the Raskin procedure, and this buys us time for few weeks for a more major procedure carried further on, which results in huge correction of the oxygen levels, which is arterial switch Jatine procedure or atrial switch mustard procedure. So we should remember that dTGA, if diagnosed antenatally or soon after birth, requires us to act immediately to start prostaglandin E1 and refer to a center where balloon atrial septostomy can be carried out, so that the initial few weeks of life are possible. And this is the timeline from birth to week 2. Week 2 to week 3 is the window of opportunity when we have to carry on the arterial switch, because after that the chambers, they adapt to the pressures. The left ventricle will adapt to the pulmonary pressure, so it will atrophy, and after that the arterial switch procedure will not be successful. So we have to carry out this procedure by week 3 and maximum week 4. So sometimes examiners are very fond of asking what is the difference between cyanosis of TGA and what is the tetralogy of Fallot. So we should remember that the problem with the tetralogy of Fallot is the PROV, that is pulmonary stenosis, right ventricular hypertrophy, overriding of aorta and ventral septal defect, whereas parallel circulation is the anatomy of TGA. The onset of cyanosis is soon after birth in TGA, whereas it is often delayed and intensity, and it is triggered by strenuous activity, which is known as TET spells. The clinical relief of cyanosis is brought about by mixing procedures by prostaglandin E1 or the septostomy, and in TOC the hypercyanotic spells are corrected by squatting procedure. On X-ray we have an agon string appearance in TGA, and we have a boot-shaped heart in TOC. So guys, this is all what we want to discuss about dTGA, and it was a condition which was once uniformly fatal, but now many facilities are available and patient should be sent to a center where this atrial septostomy and arterial switch operations can be carried out. Once performed in timely, they can do a major biological miracle and the patient can have normal life expectancy. So guys, remember this motto in life, that life is beautiful, make it beautiful and feel it beautifully. Thank you for watching this video, and thank you once again.